Imagine a surgical puzzle, just incredibly intricate. One where solving it means navigating this landscape where multiple lifelines are, well, at immediate risk. Today, we're diving into a really foundational piece of research, the 1993 paper Experience with 1,509 Patients Undergoing Thoracoabdominal Aortic Operations. Okay, this study was really the first comprehensive look at how to approach and improve the incredibly delicate repair of these extensive aneurysms.
Yeah, and if you've ever wondered about the step-by-step progress in a very specialized area of surgery, and the crucial early insights into what makes these high-risk procedures even riskier, then this deep dive is definitely for you. We're going to explore the key discoveries of this important work and try to understand why it still matters today.
Right. This study, led by Lars G. Svensson, and importantly, drawing on the just immense experience of Dr. E. Stanley Crawford, it meticulously examined 1,509 individuals. All of them had undergone open surgical repair of thoracoabdominal aortic aneurysms, or TAAAs, as they're known between 1960 and 1991. Now, these aren't your everyday aneurysms. A TAAA is when the bulging and weakening of the aorta, the body's main artery, spans both the chest and the abdomen. It makes any repair incredibly challenging.
Definitely. So our goal in this deep dive is really to extract the most significant understandings from this paper. We want to appreciate the immense hurdle surgeons faced back then and see how this research became, well, a cornerstone, influencing many of the surgical techniques still used today.
Okay, let's unpack this then. The central question that this massive study aimed to answer was, what factors were most closely linked to patients dying early or experiencing complications after this TAAA surgery? What were the really critical questions the researchers were trying to get to the bottom of?
Essentially, they were trying to understand who was most vulnerable during and after this major operation. And, what elements of the surgery itself, or perhaps the patient's health beforehand, were contributing to poor outcomes. They were looking for trends, really, across a large number of patients to pinpoint the most important areas for potential improvement.
And the sheer scale of this study is remarkable, isn't it? Over 1,500 patients. That's just a huge number for such a specialized procedure.
Absolutely. It was what's known as a retrospective cohort study. So that means they looked back at a large group of patients who had already undergone this surgery and analyzed their data. The fact that it included 1,509 patients all having their very first TAA repair provided an incredibly rich data set, a gold mine, really. And they also tracked these patients for a long time, 10 years, to see how they fared in the long run, mortality-wise.
And the main surgical method at the time was primarily what they called the clamp and sew technique. Is that right?
That's correct, yeah. The vast majority of these repairs were done using traditional open surgery with the clamp and sew method. This involves temporarily clamping off the aorta, the main blood vessel, above and below the aneurysm. That allows the surgeon to cut out the weakened section and then sew in a graft. Interestingly, within this large group, there were also two smaller studies sort of nested within it. One was looking at draining cerebrospinal fluid from around the spinal cord, and the other was trying to maintain blood flow to the lower body during the clamping distal aortic perfusion. The paper does note, however, that these smaller studies didn't show clear benefits at the time, and the results for those specific patients weren't separated out in the main analysis they published here.
Okay, here's where it gets really interesting, I think. The study pinpointed some significant risk factors that were linked to patients dying early. What were the key takeaways there?
Well, several factors emerged as strong predictors of early death. These included increasing age, which, unfortunately often comes with other health issues. Perhaps not surprisingly, having poor kidney function before the surgery was a major red flag. Figure 6.1 in the paper really highlights the strong connection between how well the kidneys were working beforehand and, well, how long patients lived after the operation. It's quite stark. Other important factors were having pre-existing chronic lung disease, coronary artery disease, so problems with the heart's blood supply, and having another aneurysm located closer to the heart at the same time, a concurrent proximal aneurysm. And crucially, the amount of time the aorta had to be clamped during the surgery also played a significant role. Clamp time was key.
And it wasn't just the patient's condition going into the surgery that mattered, right?
Yeah.
What happened afterward also had a big impact on survival.
Exactly. The study found that if patients experience complications after surgery, such as a stroke or cardiac problems, renal failure, gastrointestinal issues, these were also strong indicators of a higher risk of early death. It really underscores how interconnected all the body's systems are, especially during and after such a major intervention.
Now, perhaps the most feared complication of this type of surgery is spinal cord ischemia. It can, unfortunately, lead to paralysis. What did this landmark paper teach us about that specific risk?
Yeah, that's a huge one. The paper clearly showed a strong correlation between how long the aorta was clamped, the cross-clamp time, as well as how long the blood flow to the abdominal organs, what's called visceral ischemic time, was reduced, and the likelihood of spinal cord ischemia. So time was critical. Several other factors were also linked to this risk, including if the aneurysm had actually ruptured beforehand, the patient's age, again, if they had kidney problems before surgery, and if they had that concurrent proximal aneurysm we mentioned.
And this paper really helped us understand how the location and extent of the aneurysm impacts this risk, didn't it? The Crawford classifications.
Yes, absolutely. The paper made a significant contribution there to understanding the risk of spinal cord ischemia based on how far the aneurysm extended along the aorta. These are the Crawford classifications. Initially, aneurysms that involved more of the chest area of the aorta, classified as extent 2 and I, were seen as carrying a higher risk of spinal cord injury, especially with the surgical techniques available then, which had minimal countermeasures. On the other hand, extents 3 and 4, which were more confined to the abdominal aorta, were considered, perhaps somewhat counterintuitively, to have a lower risk at that time. What's interesting to note, though, is that later, with the identification of extent V aneurysms, which are even lower down, its exclusion from the original extent 3 group revealed that extent 3 actually carried a risk profile more similar to the higher risk extent 2, so that understanding evolved.
And there's a figure in the paper, figure 6.2, that illustrates the risk of spinal cord ischemia, depending on how the intercostal arteries were managed during surgery. Those small but vital blood vessels feeding the spinal cord.
Precisely. That figure visually demonstrates the importance of, well, trying to protect or reattach these intercostal arteries during the operation to minimize the risk of this devastating complication. Managing those arteries became a key focus later on.
You know, something that really stands out, looking back at this, is the emphasis on kidney function. It seems the study found a surprisingly strong link between how well the kidneys were working before surgery and how long patients survived afterward. Even stronger, it seems, than the link between spinal cord ischemia and death. That's quite a significant finding, isn't it?
It really is. And when you look at figure 6.2, which shows the long-term survival curves, it's striking. You see exactly that the profound impact of the patient's baseline kidney health on their long-term survival after this major surgery. The authors even pointed out that having an aortic dissection, which is a tear in the wall of the aorta, another serious condition, wasn't associated with long-term survival in their analysis in the same powerful way that baseline kidney function was. It just further highlights the critical role of kidney health in this specific patient population undergoing TAA repair.
Okay, let's delve a bit deeper into those kidney-related complications then. What specific factors did this study identify as being important for predicting postoperative renal failure?
Right. So the paper detailed the connections between several factors present before surgery and the development of kidney failure after surgery. They defined failure as either a significant jump in creatinine levels, that's a key measure of kidney function, or the actual need for dialysis. And the predictive factors included, well, the patient's kidney function before the operation, obviously. Also, the presence of hardening of the arteries or atherosclerotic disease, any narrowing or blockages in the arteries supplying the kidneys themselves, renal arterial occlusive disease. Higher creatinine levels before surgery were also a sign, and again, that length of time the blood flow to the abdominal organs was reduced during the clamping, the visceral ischemic time. It kept coming up.
It's really clear this paper was such an important contribution. What is it that makes it such a landmark, such a benchmark in the field of vascular surgery?
Well, this paper is considered a landmark for several key reasons. Most notably, its sheer size, like we said, focusing on a very large number of patients. And crucially, they were all treated primarily with the same dominant surgical approach of that era, the clamp and sew technique. It really represents the extensive experience and, frankly, the surgical skill of Dr. E. Stanley Crawford and his team. You can think of it as a crucial point of reference, a benchmark that allows us to measure how much progress has been made in repairing TAAs since then. It starkly highlights the inherent difficulties of this type of surgery, where just so many vital organs are potentially at risk all at the same time.
Of course, with any study that looks back over such a long period, particularly retrospectively, there are usually some limitations to acknowledge, right?
Absolutely, yes. And the authors themselves acknowledge that. It was a retrospective study, meaning they were analyzing data that had been collected over many years for clinical care, rather than designing a prospective study from the outset with specific research questions in mind. And also, as we mentioned earlier, the specific treatment approaches for those small subgroups of patients in the embedded trials, this CSF drainage and distal perfusion ones, they weren't clearly separated out in this main report. That could have made it harder, at least based on this paper alone, to draw really definitive conclusions about the effectiveness of those specific techniques at that specific time.
But even with those limitations, it sounds like this paper really acted as a catalyst, didn't it? It spurred a lot of future investigation and innovation.
Oh, it absolutely did. Despite any limitations, this paper provided the critical motivation for Dr. Crawford and his colleagues, and indeed the wider surgical community, to really focus intensely on finding ways to prevent that devastating complication of spinal cord ischemia. Because it has such a massive impact on both immediate survival and long-term quality of life, it became a major area of research focus moving forward.
And that led to the exploration of some pretty drastic measures, it sounds like, such as profoundly cooling the body down and even temporarily stopping blood circulation altogether.
Yes, exactly. Some researchers explored using deep hypothermic circulatory arrest, DHCA. That involves cooling the patient's body to a very low temperature, maybe 15, 18 degrees Celsius, and temporarily stopping all blood flow. The idea was this would allow for a longer, safer time to repair the aorta without blood flow. However, as the paper sort of touches on, while this showed some promise perhaps in surgeries involving the upper part of the descending aorta, it didn't necessarily protect against spinal cord ischemia in the extensive extent TAAAs. And importantly, it carried its own significant risks, such as increased bleeding, particularly into the lung. So it wasn't a magic bullet.
And then there was another approach, developed by the Boston group, which involved cooling the organs more regionally, along with draining cerebrospinal fluid.
Exactly. They attempted a different strategy, selectively trying to protect the spinal cord by inserting a catheter to circulate cold fluid around it, while also draining CSF below the level of the surgery. But this technique also had its own challenges. Things like the difficulty of ensuring truly uniform cooling of the entire spinal cord, and also the potential risk of actually increasing pressure within the spinal canal if the drainage wasn't managed perfectly. It was complex.
Okay, so beyond the major issues of spinal cord injury and kidney problems, did the paper also discuss other types of significant complications?
It did, yes. The paper also noted the significance of lung-related or pulmonary complications. They linked these to pre-existing lung conditions in the patients, but also, importantly, to how the diaphragm, the main breathing muscle, was managed during the surgery. Their observations really underscored the importance of trying to preserve the function of the diaphragm whenever possible. Additionally, they addressed the very serious issue of gastrointestinal ischemia, basically, lack of blood supply to the intestines, which can occur either due to insufficient blood flow during clamping or potentially from little clots emboli traveling downstream.
So it really feels like this foundational work, this massive data set and analysis, directly paved the way for the kinds of protective strategies that became more common later on, like actively draining spinal fluid and maintaining some blood flow to the lower body during surgery.
Precisely. Building on these early crucial findings from Crawford's group, and of course the work of others spurred by this, the surgical approach evolved significantly. It moved towards incorporating strategies like routine cerebrospinal fluid drainage, the idea being to lower the pressure on the spinal cord, and also distal aortic perfusion, actively pumping blood to maintain flow to the legs, and, critically, aiming to perfuse the spinal cord arteries during the time the main aorta is clamped. The goal is really to give surgeons more time and better physiological conditions to perform the complex repair. That includes the crucial step of meticulously reattaching those vital intercostal arteries that supply blood to the spinal cord, and also ensuring adequate blood flow is restored quickly to the abdominal organs like the kidneys and gut. It became a multi-pronged approach.
It really sounds like Dr. Crawford's work, culminating in papers like this, was just a monumental achievement in the history of vascular surgery.
Absolutely. There's no question. His work, particularly in this incredibly challenging area of TAA repair, stands as a true landmark accomplishment. And it continues, even today with newer techniques emerging, to be the standard, the benchmark against which new methods and advancements are measured and evaluated. His contribution was immense.
Okay, let's try and bring it all together then. The key takeaway for you listening to this deep dive into the 1993 Svensson and Crawford paper is that it provided a really comprehensive early understanding of the multitude of risks and the typical outcomes associated with open TAA repair at that time. It clearly highlighted those critical factors like how long the aorta is clamped, the huge importance of the patient's pre-existing health conditions, and perhaps most notably, the incredibly important role of kidney function in predicting who would survive long term.
Yeah, and the real aha moment for me, thinking about this paper, is the clear statistical links they were able to establish. Connections between specific factors, things happening during the surgery, things known before the surgery, and the development of major life-altering complications. These weren't just anecdotes or educated guesses anymore. They were findings supported by a massive amount of data from over 1,500 patients. And that provided crucial insights that directly influenced the development of preventative strategies. And like we've discussed, that unexpectedly strong connection they found between baseline kidney function and long-term survival is just a prime example of a truly pivotal discovery from this work.
But why should you, our listener, care about delving into a paper from 1993? Well, understanding the historical progression, the evolution of incredibly complex surgical procedures like TAAA repair, really demonstrates the power of meticulous observation and rigorous analysis in driving improvements in patient outcomes over time. Even knowledge that might seem fundamental or obvious today is often built upon these kinds of groundbreaking, painstaking early studies. It shows how science and medicine advance.
Which leads us to maybe a provocative thought for you to consider as we wrap up. Given the significant progress in this field since this landmark paper, particularly the development and refinement of less invasive endovascular repair techniques, the EVAR and TVAR procedures, how might future large-scale analyses, maybe comparing open versus endovascular or looking at long-term outcomes with newer methods, how might they reshape our understanding of the most critical risk factors today? And what about long-term outcomes for patients with these thoracoabdominal aortic aneurysms now? What new challenges and perhaps unexpected insights might the next generation of research reveal in this continuously evolving high-stakes area of medicine?